Welcome to QD Clinic. I'm Jack Cush with Room Now. QD Clinic is brought to you by Room Now Live 2022. It's all about the discussion and the interchange. We need experts like you showing up at this meeting. You can register now. Today's QD Clinic is about steroid weaning. I went through this a few times in clinic today and yesterday. I think I need to review it again. You put someone on steroids, they feel great. It is the greatest and the worst drug we have in rheumatology, according to Dr. Peter Merkel. I always say steroids are acutely wonderful, chronically dangerous. Today, I saw my patient's eyes pop and said, you continue to take that 5 or 10 milligrams a day for the rest of your life, you're going to get fat, fatter, fattest. You're going to get diabetes, high blood pressure, stretch marks, cataracts, blindness, weak bones, fractures, common infections, bizarro infections, life-threatening infections, stomach ulcers, muscle weakness, bruising, skin fragility, thin hair, hair loss. I mean, halfway through, her eyes are popping saying, oh, what, I don't want to be on this stuff. So you need to say that up front because it makes weaning steroids easier after they've had 3 weeks or 3 months of benefiting from steroids. It's gigantically important to be upfront about the dangers of steroids with every patient you put on steroids, no matter what dose, no matter how short. Rule number 1 is you don't need to wean steroids in people who are on steroids for less than 6 weeks, meaning you haven't yet screwed up their HPA axis enough, their hypothalamic pituitary axis enough with chronic steroids. Hence, you can stop abruptly and there isn't going to be a prolonged problem with withdrawal and withdrawal symptoms. And yeah, patients need to know that this is steroid withdrawal. When you're taking away the steroids after they've been on them chronically or you're weaning them down, they feel lousy. They think it's the original disease for which they got the steroids. And you need to distinguish between those two and be certain it's not the original disease and it is steroid withdrawal, which is aches and pains, not swelling, which is more fatigue, more not feeling right, more a little bit of nausea, but they don't vomit. And their labs show disease well controlled. Their other parameters, whatever disease you're looking at, whether it's myositis, lupus, or rheumatoid arthritis, or GCA, their other parameters show no activity of their disease. So I like to go from 60 to 40 right quick. After you've been on 60 for a month, I've instituted DMARD, steroid sparing therapy. As soon as I can, I take them down to 40. It's exceptional that you don't need to. And usually those are people who need 60 milligrams or higher prednisone equivalents, often in split dose because they have such active disease, which is seldom the case and mainly only the case in something like lupus with alveolar hemorrhage, lupus cerebritis, Still's disease, bad life-threatening, organ-threatening vasculitis. Other than that, they don't need to be on those doses for a long period of time. All right. So 60 to 40 right quick. And then I've got a goal. It's 3 months. How are you going to get there? And my usual role is make changes every 2 to 3 weeks. Try to make big changes up front, meaning when they're at 60, you can go to 40. When they're at 40, you can go to 30. When they're at 30, you might need to go to 25, or when they're at 20 or 25, you need to go down by 5 milligrams. So I drop by 20, 10, and then 5 every 2 to 3 weeks until I get to a dose where usually it's going to be 12 weeks down the line, 10 weeks down the line, and you're going to have them on that dose. And there you're going to go even slower, right? You can go by 1 milligram every week until they're off. The patients who are impossible to get off steroids, this is what I do. They're at 5 milligrams. I make them go from 5 milligrams to 4 milligrams, but I make them seesaw between 5 milligrams and 4 milligrams every other day for 10 days. And when they notice no difference between the 5 and 4 milligram dose days, then they're good to stay on 4, and they stay there for a week or 2. Usually 2. And then you do it all over again. Lather, rinse, and repeat. So then you go to 4 and 3 every other day, alternating for 10 days, and then they stay at 3 for 2 weeks. You keep going until you get them off. again, you have to let them know the hazards, dangers, the misery of chronic steroid use. You know who I see most damage and consequences of steroids are, in my opinion, myositis patients. I don't think we pay enough attention to them. I've seen AVN with myositis with as little as 8 weeks of high-dose steroid therapy. Less likely to see that with even the elderly on high-dose steroids or even lupus, but I worry about the myositis patients. So again, you got to be really aggressive in steroid weaning. If you've got another plan that you like to use, and by the way, not everybody needs to go down by that 1 milligram from 5 milligrams down. Sometimes if they've only been on steroids for 3 months or so, you can probably go from 5 to 2.5 and then off. Some can go from right down to 5 and off. But you know, some people need some hand holding and coaching. You got to write this stuff out on a piece of paper and give them the schedule or give them a calendar and show them what days they need to make the changes on. Otherwise, left to their own, they're going to chronically continue to take steroids because steroids make everyone feel good, which is not really the goal, is it? Anyway, that's it for this QD clinic. Go to roomnow.live and register today. We'll talk tomorrow with another QD clinic. Take care.